Part 1. Obstetrics Examination. In this video, we will learn on how to examine obstetrics patients. We will apply 3 basic steps of examination, including inspection, palpation, and auscultation. Equipments. We'll need a measuring tape, Pinard stethoscope, and daptone. Introduction and consent. Start your examination by introducing yourself and your lecturer to the patient. Ask for patient's permission and verbal consent.
Assalamualaikum, I'm Dr. Fazilah. Before we proceed, can I confirm your name please?
My name is Maria.
I'm going to examine your abdomen. This involves looking and feeling around your tummy. It might be little uncomfortable, but it shouldn't be painful. Should you feel any pain, you can ask me to stop at any time.
Privacy. Pull the curtains to preserve the patient's privacy. There must be a chaperone present during the examination. Hygiene. Use the alcohol sanitizers before touching the patient. Exposure. For obstetrics case, the optimal exposure should be from xiphisternum to the mid-thigh. However, in order to preserve the patient's modesty, it is enough to just expose her up to the pubic symphysis, about 1 inch below the line of pubic hair. Inspection. Note that the abdomen is distended by a gravid uterus. Look for cutaneous signs of pregnancy such as linea nigra, striae gravidarum, and striae albicans. Note the condition of the umbilicus, whether it is everted or inverted. Look for any dilated veins or any scars on the abdomen. In this patient, there is a well-healed transverse suprapubic scar. Do comment if there is any visible fetal movement. Palpation. Start by light palpation on the 9 quadrants of the abdomen. Begin the palpation from the area which are non-tender. Note for any tenderness as you palpate the abdomen by looking at the patient's expressions for any grimace. During this time, look for uterine irritability as you palpate the uterus. Fundal height. Fundal height can be examined by either outlining the lateral border of the uterus or palpating the uterine fundus from the xiphisternal joint downwards. Here, we can use the ulnar border of the left hand to palpate until the first bulging resistance from the uterine fundus is felt. Now, we can start measuring clinical fundal height by making either the xiphisternal joint or the umbilicus as the reference point. Note that when the uterine fundus is just palpable over the pubic bone, the clinical fundal height is around 14 weeks. At the level of umbilicus, the clinical fundal height is 22 weeks. When the fundus reaches the xiphisternal joint, it correlates with the uterine size of 36 to 40 weeks. Try to distinguish between the uterus of 38-week and 34-week. At 38-week, there is fullness of the flank in which we cannot palpate under the subcostal margin. To continue our examination, we can measure superficiofundal height using the measuring tape. Place the end of the tape on the upper border of the uterine fundus and measure until the first bony part of the pubic symphysis. To avoid bias, ensure that you are measuring using inches. To confirm the fundal height, switch the reading obtained to the centimeter side. The grips. Leopold maneuver. The main aim in palpating for the fetal parts is to determine the number of fetus, the lie of the fetus, the fetal presentation, the location of the fetal back in relation to the maternal axis, engagement, liquor volume, estimation of fetal weight. Fundal grip. The hands should palpate from the lateral borders of the uterus upwards to the fundus. Fetal parts can be identified during this grip. Lateral grip. Palpate at the sides of uterus. Stabilize one side of the uterus using one hand while the other palpates for the number of poles, fetal back, and lie. Repeat the same technique for both sides of the abdomen. Pelvic grip. The hands should palpate for the presenting part of fetus by having the examiner facing towards the pelvic inlet. Here, we can determine the level of head engagement into the pelvic cavity. The head engagement is divided into fifths. The head is said to be engaged when 3 to 5 fifths of the head has descended into the pelvic cavity. Pollex grip. Grasp the lower portion of the abdomen over the pubic symphysis with the thumb and fingers of the right hand. This grip aims to determine the fetal part engagement and presentation. This grip is used by obstetricians. However, it is not recommended as it can cause discomfort to the patient. Estimation of fetal weight can be based on this table. There is appropriate birth weight corresponding to the gestational ages. For instance, at 28 weeks, the fetal weight is estimated to be at 1.0 to 1.2 kilograms. At 34 weeks, the fetal weight is estimated to be at 2 to 2.2 kilograms. At 38 weeks, the fetal weight is estimated to be at 3 to 3.2 kilograms. During palpation, do comment on the adequacy of the liquor volume. This can help us to detect the occurrence of oligohydramnios or polyhydramnios in the patient. Auscultation. Complete your examination by listening to the fetal heart via a Pinard stethoscope using your best ear. This should be done over the anterior shoulder of the fetus. Ensure that you create a vacuum space between the abdomen, Pinard, and your ear to help better sound transmission. You can time the fetal heart rate manually using a clock watch. Adaptone can also be used to calculate the fetal heart rate. After finishing the examination, thank the patient for their kind cooperation.
As our clinical examinations, the abdomen is distended by the gravid uterus as evidenced by linea gravidarum, striae gravidarum, and striae albicans. There is transverse suprapubic scar measuring 10 cm. On palpation, the abdomen is soft, non-tender, uterus palpable at 32 weeks with a symphysis finder height of 32 cm. It is singleton fetus with a longitudinal line, cephalic presentation with 5/5 palpable. With an estimated fetal weight of 1.4 to 1.6 kg, and clinically the liquor was adequate. On auscultation, the fetal heart rate was 145 beats per minute.